There's an emergent body of evidence that suggests that rehabilitation intervention can improve functional outcomes in cancer patients. However, integrating a rehabilitation approach and specific cancer-focused rehabilitation services into survivorship care plan and service delivery requires further development in Canada. We have a very dynamic group that is going to update us on the current work and future directions. First, I want to introduce Dr. Ringash. She's a professor in radiation oncology at the University of Toronto, site leader of the GI site group, and many other hats she wears. But more importantly for today, she was co-chair medical lead of the Head and Neck Cancer Survivorship Program, supported by the Discovery Fund. Colleen Dunphy is a physiotherapist working in oncology at UHN since 2009. She's currently working as a research coordinator and rehabilitation consultant on a 2-year research grant from the Canadian Cancer Society. And Dr. Jennifer Jones is a director of the Cancer Rehabilitation and Survivorship Program and a Center for Health, Wellness, and Cancer Survivors at the Princess Margaret Hospital. In addition, she's a scientist in the Ontario Cancer Institute and an associate professor in the Department of Psychiatry at the University of Toronto. Survive and Revive, integrating rehabilitation into cancer care. Jolie?
Great, thanks, Rebecca. So I'm really just here to give us the setup, and I'll start by saying I tried really hard to come up with as clever a title as Jim had last week, but I hear he had his secret weapon, Dr. Cummings, helping him, so probably wasn't achievable for me. Anyway, we did our best. So just some goals for our talks today, and disclosures, there are none, so that's easy. We just want to help people understand the challenges that adult cancer survivors face after treatment, to learn about the effectiveness of rehabilitation for cancer, and to be aware of an ongoing research project that's specifically for head and neck cancer patients. And as you heard, we've definitely got the A team today, and we're going to start with Dr. Jones. Jennifer. That should be your slides.
Great, thank you. Thanks for having me today. So I'm going to start by just providing a little bit of background and then describe our Cancer Rehabilitation Survivorship Program here and the evolution of it and the new rollout of our new model of care. So I'm sure it doesn't show up so nicely on the screen, but I'm sure most of you are familiar with these statistics. We know that the mortality rates have dropped significantly among the most prevalent cancer types. Up here, this is all cancers, so we're seeing that survival rates are at over 60% now when we combine all cancer types, but certainly for some of the more common cancer types like breast, prostate, and breast, we have very high survival rates, 5-year survival rates of up to 90 or more than 90%. So what this means is there's a growing number of cancer survivors here in Canada and coming to Princess Margaret. And given that we are expecting a growing number of people who will be diagnosed with cancer, but also surviving cancer, there will be a doubling of the number of individuals living with a personal history of cancer by the year 2050. This is an estimated a graph from the US, but I expect it would be the same sort of trend here in Canada. So, and you likely see this in your own practices. We know that almost all major types of cancer treatment can result in side effects. So side effects that are both acute but also persistent. They can impair well-being and physical and psychosocial functioning and patients' overall quality of life. And so, as I said, many of these symptoms that people develop or side effects that people develop during treatment are acute, and for many people they will resolve once treatment ends. But for some people, these do persist. And for some, for example, with fatigue, they can persist for many years after treatment ends. We also know that there are new late effects that may manifest many months or years after treatment ends. All these persistent and late effects they're fairly common. There are a number of them that can happen, but we don't have a great evidence base in terms of their exact prevalence and incidence or the risk factors, so who is most at risk for developing these. We do know, though, that they can be further complicated by pre-existing risk factors. For example, people who are older, people who already have other comorbidities when they get diagnosed with cancer, those with genetic risks, and also behavioral and lifestyle factors may put people at more risk of developing these persistent late effects. But all in all, we do know that the survivorship experience is a highly individual thing. So it's very difficult to predict. Everybody is a little bit different. Everybody's course of recovery looks a little bit different, which makes it a little bit of a challenge in terms of planning healthcare services for this population. So I'll just go over some of the physical effects. Certainly all patients who have been diagnosed with cancer are at risk for local and distant recurrence in second primary cancers, which is what we do when we have our surveillance appointments after treatment ends. We know that treatment can affect almost all body systems and result in these long-term late effects. They can affect cardiac and respiratory systems. There can be cognitive impairments, pain, fatigue, neuropathy, functional limitations. It can affect sleep, sexual dysfunction, infertility, and depression, anxiety. And many of these symptoms end up coexisting. So you often don't see a symptom just by itself. Somebody may present with fatigue in addition to sleep problems and depression. So they often cluster together. And as I said, they may be exacerbated by age-related processes or comorbidities. We see weight gain and obesity after diagnosis is common, certainly. We see this often in the breast site. And this can also increase risk for recurrence in second primary cancer. So lifestyle becomes an important issue in this population. Overall, survivors appear to be functioning fairly well. They report few functional limitations. I'm going to show a little bit of research around this, but certainly more limitations in their activities of daily living than people without a cancer history. And so this is actually a slide from Eugene Chang, who is our physiatrist in our program. And I like this slide just because he's sort of just highlighting all the different things that people may be dealing with after cancer treatment. He sort of highlighted a couple of different sites, but as you can see, it can be quite site specific, although there are some issues that go across all of the different diagnoses. For example, pain and fatigue you may see across all the different disease sites. Neuropathy can happen as a result of chemotherapies that people receive. So this was a large study that was published actually more than 10 years ago, but it was done through the NHIS survey, and they looked at people who had a cancer history versus those who did not. And we're looking at health status and disability. And as you can see, the gray bar here is the patients the respondents that had cancer history versus those that didn't. So there were significantly more people who had a cancer history that reported fair or poor health, more problems with limitations in terms of their activities of daily living, more functional limitations, and a higher percentage were unable to work. And in that a national health and nutrition examination study, these studies were both done in the United States. Again, they were looking at cancer survivors versus those with no cancer history, and here they're looking at physical performance limitations as well as participation rates. So this is their ability to function, basically, and finding big differences as well, with 53% of the patients who had a cancer history reporting some physical performance limitations versus only 21% of those with no cancer history, and 31 versus 13 of those who said it restricted participation in their activities. This is a study that actually we did here at Princess Margaret through our registry in the breast, colorectal, and prostate sites. Sorry, it's cut off here, but this is our patients who are. This is a fairly large sample size of almost 1,300 patients who had come through Princess Margaret, and this pink bar here is patients who were sort of in their first year and a half post-treatment. These were patients who were around 2 years post-treatment, and then, sorry, it got cut off up here, but these are patients who are about 5 or 6 years post-treatment. And what we see is using a validated fatigue scale that, fatigue doesn't really This isn't a longitudinal study, it's cross-sectional. These are 3 separate cohorts, but as you can see, the prevalence of fatigue isn't really any different between the 3 cohorts. So patients up to 5 years post-treatment are still reporting, about a third of patients are still reporting quite significant fatigue. And just to highlight what this means in their lives, we looked at sort of disability using the WHO Disability Assessment Scale. And so these are the patients here who are above cutoff on the fatigue scale, so have fatigue, versus these patients who do not have fatigue. And so 91% of the patients who had fatigue also scored with moderate to significant disability, versus only 30% of those who did not have fatigue. So I think what this highlights really is just that this fatigue is related to a very, and moderate to significant disability is quite high disability, which would impair their ability to function. I'll just move on now to psychosocial well-being because this is important as well. Patients and families also face a number of psychosocial and economic consequences as a result of having a cancer diagnosis. Certainly, fear of recurrence is probably the most common thing that we see in our patients. I think that that's understandable. I think most patients have that, but there are varying degrees of how much that affects them. So some people have very severe fear of recurrence that it becomes almost debilitating for them. Certainly a lot of people, definitely around that transition from their treatment to their well follow-up, in that immediate sort of transition time, there's a lot of uncertainty about what to expect, what their well follow-up is going to look like. Some people report anger, anxiety, just a lot of vulnerability at that time. And then we also have issues related to sexual dysfunction, altered body image, and these are also common. And there are also lots of reports of sort of changes in social outcomes, such as relationships, changes in community or community involvement, social involvement, and then practical concerns about returning to work. So work status changes for a number of people. Some people are never able to get back to the jobs that they had before. There's issues around employment and insurance. So there can be many economic implications for people. I'm not sure if any of you have heard of this. Hopefully some of you have, but in 2005, the Institute of Medicine released this really pivotal report, From Cancer Patient to Cancer Survivor Lost in Transition, really highlighting the needs of this growing number of cancer survivors and talking about what some of the essential components of survivorship care should be, including certainly prevention and surveillance, which I think we do quite well, whereas things that we're probably struggling a bit more with are coordination, and how do we coordinate care of our patients post-treatment and coordinate with our family practitioners in the community and our community partners, but also intervention. So how do we meet the needs of those patients who have those persistent late effects and address those to get them back to wellness and back to their lives as best they can. And this has sort of led to a lot of interest in the idea of rehabilitation in this population. And I'm sure all of you have heard of rehabilitation. It's defined as a planned program in which a person progresses towards or maintains the maximum degree of physical and psychological independence of which they are capable. We know that historically it's been applied very successfully in other chronic diseases. You've probably all heard of cardiac rehab. They use rehab in multiple sclerosis and COPD. And over the last few decades, there have been some cancer-specific rehabilitation programs that have started to be developed. Certainly in Germany, they have a very well-developed cancer rehabilitation program where actually all patients in Germany who are diagnosed with cancer get cancer rehabilitation as part of their standard of care. In Netherlands and some of the Scandinavian countries, they actually have inpatient rehabilitation that's part of standard of care for all of their patients as well. But in the US and Australia, there are pockets of places of excellence, I think, where they have programs similar to ours, clinics where people can be referred to and seen by rehabilitation specialists. And in terms of what cancer rehabilitation is, it's very similar to the definition of just general rehabilitation. It involves helping a person with cancer to help himself or herself to obtain the maximum physical, social, psychological, and vocational functioning within the limits imposed by disease and its treatment. And, this is a whole list of things that cancer rehabilitation has the potential to affect and improve. We know from the literature that there are physical interventions, exercise interventions, physical activity interventions can improve functional capacity, strength, range of motion, and may help alleviate cancer-related fatigue. And we also know that psychosocial interventions such as mindfulness training or CBT can help to improve psychological functioning and alleviate mental health difficulties such as fear of recurrence. In terms of, I think the literature is quite strong in the exercise or physical activity interventions. There's a huge body of literature now really supporting the effectiveness of physical activity or exercise interventions. There was a systematic trial that was done by SPEC in 2010 that included 82 trials showing large to moderate effects of physical activity interventions post-treatment on upper and lower body strength and fatigue, and small to moderate positive effects on physical activity was seen for physical activity level, aerobic fitness, and muscular strength. And this was another systematic review, meta-analyses that looked at the impact of these exercise interventions on quality of life. And this included 40 trials with large sample size, and found beneficial effects on health-related quality of life, cancer-specific concerns, body image and self-esteem, emotional well-being, sexuality, sleep disturbances, social functioning, anxiety, fatigue, and pain. And this is just for physical activity interventions. And actually the list, if you pulled all the literature together and all the beneficial effects of physical activity interventions, is quite long and quite impressive. And so many would argue that actually there's a good enough evidence base out there to suggest that physical activity intervention should really be part of standard of care now for cancer survivors. But some people have now started to propose that maybe we need to bring together these physical activity interventions as well as those psychosocial interventions in what's called multidimensional rehabilitation programs. So they include both the physical and psychosocial components, help people to develop skills to manage and manage the side effects that they may be dealing with, and to help lead to improvements, first of all, in knowledge and coping behavior and quality of life, as well as their physical functioning. The idea of combining both physical and psychosocial interventions has been combined, within one program has been developed for many chronic illnesses, and most of the rehabilitation programs in other chronic illnesses do combine both aspects. So cardiac rehab does include a psychosocial component as well as a physical component to it. There was a review recently done by Scott looking at multidimensional rehabilitation programs specifically for adult cancer survivors. There haven't been a lot of RCTs done in this, as it's a fairly new area. So 12 were included in this review, and the interventions were pretty variable. So some included supervised physical training, whereas others just had home-based programs with prescribed physical activity and diet. And in terms of the psychosocial, there was variability around. Some were just providing information and support, whereas some were really targeting behavior change using motivational interviewing or cognitive behavioral approaches. What they found, though, that there was consistent improvement in physical functioning following these types of interventions compared to control participants. It seemed that site-specific programs did not have any advantage over programs that were with mixed diagnosis, so you can mix your cancer populations. Face-to-face delivery supplemented with at least one follow-up telephone call appears most effective. And there was no evidence to support the development of rehabilitation programs conducted over very prolonged periods of time. So you can do this fairly short. All right, so I'm going to just switch gears here a little bit and start talking a bit about our program, and hopefully this background will help to illustrate or to support what it is that we're planning on doing and what we have done. As hopefully you all know, the Cancer Survivorship Program was first started in 2005 by Pam Catton, and was the Breast Cancer Survivorship Center opened at that time. And over the next couple of years, Pam and the team developed a number of clinics, starting with the lymphedema clinic, fatigue clinic, and these clinics were rolled out. And primarily at that point, the focus was with the breast site, with our breast cancer patients. But in 2009, over the next couple of years, we added the gynae site, and then the head and neck site came on board in 2013. So those are the three sites primarily that we've been working with in the history of our program. And the reason for that is that it has to do with where our funding comes from. So we have been funded by the foundation, and it started with the Weekend End Breast Cancer Walk. So our mandate was for the breast walker, the walkers from that walk, and to service the breast site. And then when it was expanded to women's cancers, we expanded to the gynae site. Head and neck came on board with some funding and interest to help us to be able to see their patients there. So we expanded to that site. We were very lucky. Pam Cotton and David Wilger wrote a CFI grant and were able to get funding to open the ELLICSR Center in 2010, which provided us. How many of you have seen the ELLICSR Center? Hopefully some. Oh, great. That's great. Because if I asked this a few years ago, not very many hands came up. So I'm glad that most of you have seen it. That's great. So it, if you've seen it, it's a fantastic space, really a one of a kind in the world, I would say. And we have people from around the world that visit us to come and see it and learn about it. But it's provided a fantastic infrastructure for us to be able to do what it is that we want to do. We share the space with patient education, which is a really nice model because so much of what we do involves patient education. And so you'll see lots of patients there all the time. We have our exercise space, our kitchen space, and then space for meeting with patients, as well as having staff meetings as well. So once that space opened, we were able to launch our ELLICSR Kitchen program, which is a very, very popular program. There's monthly drop-in classes, but we're also now developing targeted interventions that have to do with diet. So one intervention that we're working on right now is in the gynae site, targeting women who have had pelvic radiation and helping them to deal with bowel side effects from that. So how do they adapt their diet and prepare their foods in different ways to try to manage some of those side effects. In 2004, we launched the We Can program, which is our wellness and exercise for cancer survivors. This is an exercise program. The team involves kinesiology, and our physiotherapist is also involved primarily. So people can refer patients to this. It's a home-based exercise program, but they get referred, they get assessed, they get a prescription, they get bands and a ball and a mat to take home with them, and they can come in at specific times to get reassessed and have their prescription adjusted as needed. So the idea is just getting people well and active. And this year we have launched what we now call our program used to be called the Cancer Survivorship Program, the Cancer Rehabilitation and Survivorship Program. And our mandate is to roll this, our program and our services out to all cancer sites here at Princess Margaret. So this is just a chart to show you a little bit about our history over our first 10 years leading up to this year. So, we started in 2005, and by 2014, sorry, I don't have 2015 data here, we were seeing, just over 1,300 new patients and 3,800 visits with our patients. So lots of volume, lots of patients coming through. Again, this is just with our breast, gynae, and head and neck sites. So this is great. And the way it had been structured was that we had these 4 standalone clinics as well as consults. So people could be referred to the fatigue clinic, functional mobility clinic, lymphedema clinic, and neurocognitive clinics. As well, they could see our physiatrist, have a consult for return to work or for sexuality. And our clinical team is made up of a really great multidisciplinary team that includes physiatry, physiotherapy, occupational therapy, kinesiology, neuropsychology, social work, and we have a dietitian. Have I missed anybody, Stephanie? No, good. Pardon? Massage therapist. I knew I was right. And also Jeremy, yes, who is our wellness chef. So, yes. So this leads us now to where we're at right now, which is our new initiative is to develop Canada's first integrated cancer rehabilitation program. And we are rolling this out this year. The goal is to build Canada's first comprehensive interprofessional integrated cancer rehabilitation program, addressing the chronic and late effects of cancer. And we're building a longitudinal evaluation to build some evidence around this to look at its impact. So why is it that we're changing from our old model where we had our clinics that people could be referred to and our model now? So the way that it was before, the intake process, people would get referred, they would have an assessment by the person who was running that clinic, and it really didn't allow for interdisciplinary assessment. There was a lack of integration between the team members, and some delay could be resulting in delays in addressing patients' needs. But also, if somebody came to the fatigue clinic, they would have to get assessed there, and then if they went to the neurocognitive clinic, they'd have to get assessed there, and if they went to the functional mobility, they'd get assessed there. So there were multiple assessments. And the idea was to try to integrate it all into one comprehensive assessment that's done by the team. The current model is not patient-centric enough. I mean, certainly it's a patient-centric program, but again, this idea that there are multiple follow-up visits on different days and that it results in higher costs and more days off work, and that this, can decrease patient satisfaction with our program. And finally, I think the biggest thing is that the current model really isn't sustainable, given the size of our program, the size of our team, and the fact that we are now rolling out to all the disease sites at the hospital. So we needed to figure out a better way to streamline our patients and start looking at more group. So in 2016, we started this actually formally in March, where everything got rolled out. Every patient now who gets referred to our program, they don't have to get referred for a specific clinic, so you don't have to refer to fatigue, whatever, you just refer to cancer rehabilitation, survivorship. They'll come in, we do a comprehensive assessment by a member of our team within a reasonable time frame. What's the wait list right now, Stephanie? It's about a month now from when we get the referral to when they can have their assessment. And then an informed collaborative decision is made at the end in terms of what their care plan is going to look like, where they'll be triaged to. We have now developed a new group-based cancer rehabilitation program that eliminates the need for multiple follow-ups. And we will be rolling this out to all the sites here at Princess Margaret, so you can be referring your patients. So we're calling it Cancer Rehabilitation Survivorship 2.0. We do have a new referral form. I don't know if any of you have seen this in the clinics. We are now integrated with the Dept system, so if certain scores come up on Dept, that should flag a referral to cancer rehabilitation. So that will help to inform those decisions for you. As those referrals come to us, we do an EPR and an intake screening to make sure people are eligible for the program. We then have the multidisciplinary assessment, and then we've developed a new triage criteria and patient flow map to really make decisions on where the patients need to go. And it's very much based on this triangle here where, people who have very low, not mild to low impairment or disability get referred to our community partners, and I'll get into that in a minute. And that's, about half or 50 to 60% of our patients. Those people who have more moderate complexity can go through our group program. And then the small percentage that have quite a severe disability will be referred with our partners, and we're collaborating very closely with TRI in this. So this is a little bit messy, and I've actually made it less complex, if you can believe it. But this is our HighLevel Process Map, and so basically the referrals received, we screen that. Is the patient eligible? Yes, they get their assessment. And then based on their level of complexity, they get triage. So if they're low, they get discharged to wellness programs. If they're moderate, they get then further assessments. So we do a clinical assessment to figure out what their exercise prescription will be. And then if there are no barriers, they would get put into the structured rehab program. And if they're moderate to high, they see our physiatrist, who then decides whether they need direct therapy or not and refers them to TRI or PT. So patients with none to low disability are now getting referred directly to community supports or hospital-based classes. So these can include our Wellspring partners, Willow, Gilda's Club, also classes within our own wellness program. So the weekend, the kitchen, mindfulness, or patient education classes. And what we've done is we've really made this quite more of a formalized approach. So there's actually a referral that goes to our community partners when our patients get triaged to that. So that they very much understand, and our partners understand this is a patient coming from us. We can provide information to our community partners on what the issues are for that patient. And it just helps it for the patient not to feel sort of dropped, or and hopefully allows for some better coordination of care between those programs, but also allows us to really take advantage of all these great programs that are out there, because we can't do it all ourselves. So we need to be having stronger, I think, connections with these programs that are out there. And then this is basically what our structured program looks like. It's a group 8-week program. So patients who are considered candidates for this 8-week program go through this. They have clinical metrics done, and then they get put into this program. The program consists of always 1 hour of exercise and then an hour of self-management education and goal setting. So we have these different topics. I think some of this is changing a little bit because we're just piloting it and getting feedback from our patients. We do have metrics that we're measuring at baseline, and then at the end of the 8-week program, and then at 3 months post that. As well, we do still have our lymphedema clinic, because for some of the patients, that's all they need. They're just getting referred with lymphedema. They don't need a structured rehab program. And that our lymphedema clinic is really quite a busy clinic, and there's lots of demand from actually all of our sites now, because we know lymphedema doesn't just affect our breast site. So our massage therapist, Pam, is running most of that and is really working to develop some group lymphedema classes to teach bandaging and those kind of things in group, to try to address the growing needs of patients and the growing number of patients that are coming to our program. We also offer return to work consults and sexuality consults separate from the group program, because these are very individualized. So what we do is we try to structure them into the 8-week program. So maybe on week 4 they come, they have their 2-hour session, and then they would have their sexuality consults when they come in for that. So there is some tailoring involved in the 8-week program based on people's needs. And then, as I said, for those with moderate to high, they may go into the MSK program at TRI, get direct therapy, and after that, once they're medically clear, they can come back to our program and go through the 8-week structured rehab. And so I just want to finish by just talking about sort of future priorities. So this is, we just launched this in March. We're hoping to take the next year to roll out to the sites, let the sites know, work with the sites that we traditionally haven't worked with before to find out what are the rehab needs of your patients. Work to figure out how to make sure that those referrals are coming to our program, that they're appropriate referrals. So we'll be doing that, and also, getting feedback on the actual 8-week program and revising that. But our goal after that is that we will also develop a virtual cancer rehabilitation survivorship self-management program for those patients who are not able to come to an in-person 8-week program. And this actually was recently done in the cardiac rehab program at TRI, where they've developed Cardiac College, which is an online cardiac rehab program for patients, again, who are unable to come to their in-person. And we would model it very much along the same lines as what they've done in cardiac rehab. So that's our goal, because we do know that it's difficult for some patients to be able to come once a week for 8 weeks for rehab. And so we still want to be able to reach those people who live far away or who are back to work and not able to take part in the in-person program. So stay tuned for that. So thank you very much.
Great, thank you, Jennifer. I mean, that's just incredible, and we're so fortunate really to have this resource. So it's really up to us now, I think, to start integrating our patients and sending them on as appropriate to do this. So I'm going to switch gears a little bit, because I'm going to talk specifically about the world of head and neck cancer. And, we have partnered with ELLICSR, now the Survivorship and Rehab Program, for a long time now, for several years. And we find that many of the resources and clinics they've provided are extremely helpful to our patients, but it is a fairly unique population in many ways. And some of the challenges they experience are quite different and unique and requires specialized expertise that is not always easy to access in a program that's geared for all cancer patients. What we're looking at here are just some of the physical sequelae, some of the things we can see that happen to head and neck patients. There's a lot more things under the surface that we can't see. Jennifer talked about the psychosocial aspects, but in our head and neck patients, there's issues like not being able to go out for a meal with friends or family. I mean, if you can't eat, you're limited in a lot of your social activities. That's something we can't see. Some of them can't speak, they can't hear. There are the emotional aspects, the sexuality issues for head and neck patients. We haven't really even delved into that very much yet, but huge issues. You know, how do you kiss your partner if you have a tracheostomy or you have a deficit in your mouth, in your oral cavity? So, you know, a lot of things that are quite specific, and some of the rehab techniques are also very individualized and very specific for these patients. So consequently, when we first started the Head and Neck Survivorship program in 2011-2012, Maureen McQuestion and I, who co-chair the program, we started looking into some of the background and the research, and we did an internal and external scan of what was out there. And I think really this slide from the NCI in the US from 2008, although it's a long time ago, it pretty much is still current in terms of the state of knowledge right now for head and neck cancer survivorship in particular. And there's a number of things here I just wanted to highlight since we're talking about rehab today. First of all, the issues of head and neck cancer survivorship are not very well understood by those who have never been through the experience or had contact with the experience. And we have for example, many of our patients will try to contact a physiotherapist in their local community, and the physiotherapist will say, "Oh, you have head and neck cancer. Gee, I don't think I can treat you because I don't really know about that." They're afraid to touch the patient. So there's really a need for community resources who can work with and understand these patients. The physical functioning really appears to be key. So while these psychosocial issues are very significant in our patients, we find that it's actually hard to even get to the point of talking about those things unless we deal with the immediate physical function. We have a very high rate of referrals to psychosocial oncology. We also have one of the highest rates in the hospital of the referrals not showing up. So the patient agrees to see psychosocial, they never go. So although we're trying, there's a real disconnect there. And I think part of that is because people are so focused on the fact they can't eat, they can't talk, their mouth is dry, they're very focused on those physical issues, and you kind of have to provide them with some help with those things that are immediate in their mind before they're ready to deal with the depression or the anxiety or the other issues. And finally, there is a lack of resources to support rehabilitation. And we've heard about what's been developed here, which is fantastic, but really just opening up to the whole population of our hospital in the last few months. And certainly when you go out of communities that have major cancer centers, there's really very little that's focused on cancer at all, let alone head and neck cancer. So we have some internal data as well, because one of the things we did under the leadership of Meredith Giuliani, who's here today, was a very nice cross-sectional study of patients in our Wharton Head and Neck Cancer Center using an instrument called the CASUN, which is looking at unmet needs in cancer survivors. So these were all head and neck cancer patients. And among some of the top, most frequently cited unmet needs, there's a lot here that are relevant to rehabilitation and particularly to the research that we're trying to do. So people said they needed local healthcare services in their home community. They needed someone to contact to find those services. They needed help managing side effects and help adjusting to changes, both quality of life changes and changes in their body. And they needed help to move on with my life. And to me, that really is about rehabilitation, moving on with your life, not being stuck in this post-cancer, where am I limbo. So back in 2013, with all of this information about what our patients needed, I was actually able to partner with Sarah McEwen, who is a brilliant physiotherapist researcher based at St. John's, who's really building her career in cancer rehab. And we got a small grant from the university, Grant Miller Funds at U of T. And we started out, first of all, with a literature review. And then we moved on to some focus groups. We had focus groups that were based both here and at Dept. We had about 40 individuals who were patients, family, or providers, specifically head and neck, so people with head and neck expertise. And we asked them about rehab and cancer and head and neck. And we talked pretty broadly. It was a very qualitative study. And some of the things that came through unanimously, whether we were talking to patients, families, providers, fatigue, pain, range of motion issues, stiffness, swallowing, eating. Those were the things that came out every time. There were lots of other issues, but those ones were absolutely across the board. And the advice we were given was that any kind of intervention should be scheduled as part of the routine care. It shouldn't be something special that the patients have to go to or access. It should be brought to them. It should focus on the patient goals, not necessarily our goals as providers. So, we might look at somebody and say, oh my God, this person's in terrible shape. He's so depressed. But he doesn't want to talk about his depression. He wants to talk about his dry mouth. That's what his goal is, because he wants to be able to speak in his workplace again, and he can't do that. And it was interesting because as providers, a lot of us thought maybe this should happen up front. Maybe we should be preparing patients even before they went through treatment. They didn't want that. They said they wanted this after treatment when they were recovering. They said that at the beginning, they're too focused on the cancer. They just want to get rid of the cancer. And it's only after that's gone that they start saying, wow, what do I do now? And specifically, the quotation that I liked is they asked for a person at the cancer center to guide you back into the rest of your life. So we took that pilot information and we actually went for a bigger grant from the CCSRI through the Innovation Grant Program. And we were successful. And so we've got this great grant that we're working on right now. It's using an intervention mapping approach, and I'll tell you more about that in a second to the extent that I know about it. Self-management and goal setting are the theories behind. We're using a lot of motivational interviewing techniques, and we're integrating this within the head and neck clinic. So the Wharton Center has been very supportive of that. And the goal is that this will happen as a routine assessment post-treatment. Right now it's a study, so of course patients have to consent and come in, but we're doing it sort of in a way that would integrate as routine. And they work directly with a rehab professional, which is Colleen Dunphy, and you're going to hear more from her in a minute. We went through an alpha process, which was based on this literature review and focus groups, as well as expert investigators and an advisory panel, including end users. So we're building the knowledge translation piece into the program as we go. And there was a one-on-one iterative patient piloting where we recruited patients that were willing not only to go through this consult process, but also to kind of give us feedback about the process as we went. And every single one of these interactions was videotaped, and the team watched it, and we gave feedback, and we changed. So for every patient, it was a little bit different, so we could get better and better and more efficient as we went. Now that we've gotten to the point that we kind of have a process that we think works for most patients, we're doing a beta testing where we've got 30 patients and we've got outcomes that we're measuring as we go, and we're doing it in a more structured, routine way. And so far, we've recruited 12 of those 30 patients. Now, there's another whole piece to this grant that we really don't have time to talk about today. I think Colleen will touch on it. But the other piece to this grant is that we actually built a website with all sorts of information that's specific for head and neck cancer patients about rehabilitation. And we went out to the whole catchment area for Princess Margaret, where all these patients actually come from, their home communities. And we are building a compendium of rehabilitation professionals in those communities who are willing or comfortable to work with and see head and neck cancer patients. And that's really important in this process because we want to eventually be able to send these patients back to their home communities to get the supports they need. Now, I told you I'd talk about intervention mapping. I'm only going to talk very briefly because I'm really not an expert. Sarah McEwen is the expert in this. So intervention mapping is actually a very complex, very well-defined. It's got, the book about it is about that thick. And it's got 6 very discrete steps of what you do when you're trying to build a new intervention, sort of just out of nowhere. But really what it boils down to, I think, simplistically at least, for clinicians like me, is this sort of cycle that we're all used to seeing, where every time you have new knowledge, you put it into action and then you evaluate. And you keep going around and around in this circle. So what intervention mapping does is it has 6 very discrete steps, but at every one of them, you're doing this. At every one of them, you're saying, okay, now we've created a pilot of what we think this might look like. Let's go through this loop and see what we can learn. And basically, that's what we were doing with every single patient in the alpha testing phase, so that we're building this as we go. And we have this very structured, but also very diverse group of people who are our advisory panel, who are also bringing inputs several times through this process, so that we can make sure that what we're building isn't something that will only be useful, say, in the Wharton Center at Princess Margaret, but something that hopefully could be useful in other cancer centers and maybe even other populations, if it works. Of course, we're still testing it. And I just want to give a shout out to absolutely everybody that's been involved in the Head and Neck Cancer Survivorship initiative, because they're amazing, and especially the people that agreed to sit on our steering and research committees. And most of the people that have been involved in this project are also involved in that sort of bigger picture for us in head and neck. And that's really all I had. And so now we're going to move to Colleen.
Okay, so I know we don't have a ton of time, so I'll try to be as quick as I can. So just to get into what Jolie was talking about a little bit more specifically, to let you know what I'm working on and what we're working on. So right now, we've called kind of this whole process the Rehabilitation Consult. And what that looks like is we're recruiting right now in about 3 of the head and neck clinics. And we're looking for patients that are between 1 and 18 months post-treatment, and that can be any combination of surgery, chemo, radiation. They do have to be able to communicate in English, so not necessarily speak, but communicate in some way with us in English, and no significant comorbidities, so nothing where we would expect them to have a functional decline while they're participating in the study. So really there's 4 sessions. In the first one, they do all their outcome measures, and they meet with me for about an hour. In the second session, we do a quick follow-up. So, as long as the person has goals and has a need for a follow-up, I follow up with them about a month after that first session. And then they have 2 more research sessions where they fill out their outcome measures. So in terms of the content, as Jolie mentioned, we kind of built this using that intervention mapping process, but there's a brief orientation where I let them know about the study and really lay the groundwork for what the session is going to include. So going through the process of setting goals, coming up with an action plan, and I'm trying to be very clear with them that even though I'm a physiotherapist, we're not going to be doing like a traditional physiotherapy assessment, and they're not going to be coming back a couple times a week to see me for treatment or anything like that. And the very first thing we do is we've developed a tool that we call the BRASH. So it stands for Brief Rehabilitation Assessment of Survivors of Head and Neck Cancer. And what that was actually built from that intervention mapping process, from the lit review, from the focus groups, pulled together a list of potential concerns. So it kind of acts as a little bit of a prompt list, and it's specific to head and neck patients and kind of goes through anything they might have an issue with. So it could be anything from something physical like dry mouth and swallowing. It could be more cognitive around memory, or it could be more related to activities and roles. So, I'm having trouble doing my day-to-day work, that type of thing. So they review that at home after they've consented and then bring that back, and we go through that. And that really helps us then to set the goals. So we look at the things that are of concern to them, but they might not necessarily have rehab goals about, but we're also looking at, obviously, then the things they do want to discuss rehab for, and letting them pick some goals based on those things. And then the bulk of the time is really spent in that action planning phase. So sometimes they've already got something that they've started and is in motion, and they need encouragement or they need some guidance on that. Other times they have no idea where to start, and they might need us to give them some information. They might need us to make a referral elsewhere. And we also try to build in a bit of a coping plan. So thinking ahead to what types of barriers might come up when they're trying to implement that plan, and how they're going to get around that. And then we're really basing that whole thing on a strategy called goal, plan, do, check. So much like the circle you just saw from Jolie about the intervention mapping, we're trying to teach them, to set a goal, come up with an action plan, carry that out, and then evaluate it. Say, was it effective? And the goal is that they would actually be able to do that independently. Currently, I act as a little bit of the check when we do that follow-up, but if we're successful in promoting self-efficacy and self-management, then the hope would be that they could do that independently. And then we just summarize everything we've talked about, what the plan is, and plan the follow-up, whether they need to come back and see me or they're going to go straight to the research assessment. So that takes about an hour overall. So in terms of what we think is different and what the innovation part of the innovation grant is that, we think it's a very transdisciplinary, holistic screen. And what I mean by transdisciplinary is that for me as a physiotherapist, traditionally I may have been limited by what my scope of practice is. So for a lot of our head and neck patients, their needs are so diverse, as we were talking about. They have speech and swallowing, they have diet issues, they have psychosocial issues, they have physical issues. And what the BRASH has allowed us to do, I think, is is look at those issues and set some goals without needing specific expertise in a particular field. So it was designed so that whether you're a physio, whether you're an OT, whether you're a speech language pathologist, you could deliver this same assessment, the same intervention, and be able to provide a comprehensive overview. So, like I said, from the brush, we come up with the goals. And, you know, again, we talked a little bit earlier about how we're already patient-centered, but we want to be more patient-centered. So we've really just let the patients drive the goals. So, you know, they have goals that we may not have thought were priorities. They have goals that, you know, when I was on inpatients, we always had to be, you know, SMART goals. So it had to be specific and measurable. And we kind of threw that out the window because patients had a really hard time grasping that concept. And a lot of them didn't necessarily want to get so specific, but they certainly had things they wanted to work on. So we didn't want to limit what their goals were based on it needing to be SMART. So we've really let them take the driver's seat in developing their goals. And then, of course, using the cognitive strategy, the goal, plan, do, check process. It's been tested a lot in pediatrics and in adult stroke survivors, but hasn't been evaluated in cancer survivors that we're aware of. We also came up with a new self-efficacy tool that we created based on Bandura's guide. So originally we were using a self-efficacy gauge as an outcome measure, and we just didn't measure exactly what we wanted. It was a very physical, performance-driven measure, and we wanted to know, were people more confident in their ability to manage their rehab? And that wasn't coming out previously, so we developed a new questionnaire to look specifically at rehabilitation and rehab goals. And then finally, as Jolie mentioned, we tried to make it easy to find some resources. So we came up with the website, and this is what it looks like on the front page there. So it's HNC, as in head and neck cancer, rehab.ca. And really the main components of it, there's a lot of information there, but the main components are the list and the map of clinicians that we talked about. So patients can search on a Google map, they can search using a number of drop-down menus, and it's really all the different categories include, you know, a specific professional, so they can search for a PT, an SLP, they can search by people. We specifically asked people if they had head and neck cancer experience or just general cancer experience. So those are two drop-down menus. There's one where there's a fee involved or not. So patients can kind of select by what's important to them and find a therapist or a program closer to them. There's also a section called Survivor Resources, and the list has actually grown since we took this screenshot, but there are a number of topics there that are listed pretty much in the same way that they are on the BRASH tool. And so you have things like exercise, fatigue, lymphedema, nutrition, and every page has a resources section where they can download something, they can watch a video, that type of thing, and a find help section. So if it's not enough for them just to watch something or read something, they can actually look for a program or a therapist that can help them directly with that issue. And of course, it always links back to the searchable database. And then finally, even though the website is meant to be patient-facing, we also have a healthcare professionals section and include information on some general cancer rehab, but then also some head and neck specific topics and links to other training programs. And I think the one thing that Jolie didn't mention is that we hope to eventually have another grant where we'd actually look to do some more standardized training for healthcare professionals around head and neck cancer rehab. So as we mentioned, you know, we're looking to recruit 30 to 35 patients. We've got 12 so far. When we did the alpha testing, we really didn't do any detailed data analysis because, as we said, the process was changing. It was really about getting the process in place, but the preliminary results have seemed fairly positive. You know, any of our outcome measures that deal with quality of life, like the FACT head and neck and the SF36, have been showing some potential positive trends, and we also had some positive changes in self-efficacy. Retention rates were pretty much what we expected, given that this is not a clinical trial. So we had about a 50% retention rate to get people right through the entire process. We did have a small sample size, so we ended up consenting 12 patients, and we had to exclude the 2 at Dept, actually. So we had 10 patients here at Princess Margaret. So we acknowledge that it is a small group, and they were somewhat cherry-picked patients because we needed them to give us feedback. So, you know, I think they were all employed. They had fairly high socioeconomic status. They were all very self-motivated, a really good group of patients to work with for our purposes initially. And also the feedback, though, that we got from that group was all very positive. So there was a lot of comments around the information that they received. People were very happy to get some extra information. And as one gentleman said, not just the information, but confidence that he was actually doing things right, and that he wasn't pushing too hard. And then a lot of comments also about kind of the psychosocial support and just having someone who was following up with them, so they didn't feel like they were just kind of dropped off afterwards. And they really appreciated having that hour to sit and talk with someone about their rehab needs. So just to give you an example of some of the goals that people had set, some of them were what you'd expect: returning to work full time, reducing swelling from lymphedema. Sometimes they got very specific, like eating a tomato and cucumber salad. Sometimes they were less specific than that. And sometimes, for example, one gentleman wants to move to Europe, and and I said I gave them free range, but without giving too much away about the patient, that is actually a realistic goal. So I didn't let them just pick anything they wanted, but that was actually something they wanted to do and were able to do if they got certain things in order. So some of the things that have come out of this process, I think, the first thing, I think both Jolie and Jennifer already alluded to, is that the goals were often not what we expected. So I had a gentleman recently who was talking lots about his shoulder stiffness and couldn't reach overhead and couldn't do all these things. So we talked about that for quite a long time, and I said, well, so what would you like to work on? And he kind of like puts his head down. He has on this trucker's hat, and he says, the emotional stuff. So our goals were actually nothing to do with the shoulder, and very much with some emotional stuff, as he put it. So not at all what I was expecting to come out of him. But the other thing was, actually, I was always surprised with how many people are willing to come back to the Princess Margaret. So right now, as we said, it is a study, so we haven't been able to incorporate it into clinic, and people are coming in, like the gentleman yesterday came from Collingwood, and we've given people the option to do follow-ups and things by phone, and of this group that we've recruited so far, all but one have actually asked to come back and do the follow-up in person. So lots of people coming back for things that was surprising. A comment about the community resources. So, obviously we put them all on the website. We had to do a very big scan to get a lot of those, and they actually weren't as bad, I think, as we were initially expecting. Certainly very Toronto-centric, which wasn't surprising. But some of them, I think, were just very underutilized, and I think a lot of that has to do with the fact that people just didn't know where to look for them. And even, for me, who's been doing this for 7 years, there were things I didn't know about. I'd never heard of them before. So putting them all in one place, I think, has helped to capitalize on some of the things that are already out there, but obviously we would like to build some more capacity down the road. And then the last comment is a little bit of a joke, but not really, because as Jolie said, we videotaped all the sessions, and as we would go back and watch them, myself and Sarah, the other PI, would joke about how many people cried. Like, everybody cried with me for what, I have no idea why, but maybe it's just me, but there was a lot of crying that happened during this process. So the feedback was good. People enjoyed it. So I think maybe they just needed to get that out to someone. So my final slide, just about our next steps. So we'll continue testing until the end of the summer. We figure it'll take us that long to recruit the full 30. The alpha testing paper, based on kind of that development phase, is under review right now. We hope to submit that in the next couple of weeks to have that published. We do also want to apply for a bigger grant to do a multi-site trial and be able to have bigger numbers to draw on. And then finally, we want to spread the lessons that we've learned, because I think we have gotten a lot of valuable information even from the small group. And, not just from the entire study, but even smaller components of it. So, for example, the BRASH tool that I talked about, I think we found that really useful and have not seen something quite like it in the rehab literature. So we do have a summer student who's going to be working on helping us validate that a little bit further, and hopefully we'll get that published as well.